Go.
Hi. Hi, everyone. This is Dr. Razia Fatma from Pakistan. And currently, I'm the Chief Researcher at the Common Unit to Manage TB, AIDS, and Malaria, and also Vice Chair TB Section, the Union. I'm honored today to chair this session with a very interesting and thrilling title, which is Aim and then Possible Mission, TB Care in the Low Research Setting. When I look at all the interesting sessions of global importance to end TB, I really think it is a possible mission. Without wasting any time, let me take you to title of the first presentation, which is Enabling Member Parliaments to Support and Take Ownership of India's TB Program. The next presenter would be from Kampala, Uganda, and the presentation would be 99 dots for TB treatment supervision in Uganda with adherence rates and acceptability. Third interesting presentation would be from Singapore, and the presenter would talk about the determinants and delayed diagnosis and treatment of tuberculosis in high-burden countries, a mixed method systematic review and meta-analysis. The fourth presentation will be from Hind Al Sayed, the effect of depression and anxiety and other risk factors on adherence to the anti-TB treatment in Philippines. The fifth presentation is also very interesting. It's on the impact of HIV test and treat policy on the incidence of TB and HIV population in East Central Uganda. And it will be presented by Rodrigo from Uganda. The sixth presentation title as Utility and Benefits of TB Molecular Bacterial Load Assay to Monitor TB Therapy in a Resource-Limited High TB Burden will be done from speaker from Tanzania. So I'm not introducing speakers because we will have, question and answer session at the end, which would be 20 minutes, and you will hear a presentation for next 50 minutes. So let me just tell you the last presentation title, which is Using TB Care Process Mapping to Improve Treatment Retention and Treatment Success Rate in Low-Income Settings, Experience from Central Uganda, presented from Herbert Kasama. So I hand over now to the presentations.
Thank you for taking the time to view our presentation on fostering ownership of the National TB Program amongst parliamentarians in India. My name is Dr. Indira Bihara Pankha, and I'm representing Global Health Strategies and the work that my team has done. So very quickly, what I'm going to be talking you through today is why we decided that it was important to engage political leaders, give you a slight overview of our experiences in the past, and then go into our intervention as well as the details on how we did it, the tools we used, and some of the lessons that we learned. So what we do know is that political leaders are extremely important, and political will is extremely important in the success of any public health program, simply because of the diverse roles and responsibilities that leaders in a country play, from whether it's deciding the policy discourse at a higher level, or even being role models for people to take on better health behaviors, be more informed about health, and change their attitudes and practices with regards to health. What we did realize is there were three things that they could do for TB in India. One, of course, was reviewing the program and working in a more localized manner and decentralized manner with district TB officials to address issues at the ground level. And looking at whether they could raise it at something called the Disha platform, which looks at their district's development. The next thing that they could do was also catalyze multi-sectoral action by bringing different departments together, and even public and private sector together, and really encouraging all of them to work together to end TB. And finally, of course, they play a big role in mobilizing resources, whether it's from their own kitties to ensure development in their areas, or at a higher level from the corporate sector through CSR, or even by working with states and the center to make more fiscal space for an issue. Now, what we have seen in the past is that through our experience with the Global Coalition Against TB, is that What political leaders can do if they are sensitized, if they have the right information, is really spotlight the narrative of an issue in the policy dialogue of a country. So we managed to see TB becoming a priority in the overall policy discourse of the country. And furthermore, the more they saw things that they could do and how they could actually contribute to making that kind of change, the more ownership they took of the success of the TB program and reaching some of or helping the TB program reach, come up with new ideas and new strategies and reaching its targets, whether it was through mobilizing more resources or encouraging new tools and diagnostics. Political leaders have begun to play a very supportive role. And so we thought, why not try and translate some of this from a higher level to ground level action, because the rhetoric was good at a higher level, but we did see a role for them to play given the right information. And that's where GHS put together a dashboard or a checklist with indicators that we adapted from the National TB Program's own metrics that they use to assess themselves, and in consultation with them as well as the WHO. And looking at, of course, all of the metrics that they were anyway using, along with a few more with reference to the NTP's operations, we felt that if we are able to, if policymakers can capture the data and visualize it, and they get it from the district officials, then it will help them actually find solutions where they see challenges and gaps coming up. And so we were able to sensitize as a pilot, a group of MPs and members of the Legislative Assembly. And based on our initial outreach and our initial work with them, 11 MPs and 3 MLAs used the tool that we created across 6 states in the reviews that they conducted with district TB officers, and where they were able to identify gaps or areas that the district TB officers were finding challenging. They were even able to help them take follow-up action and find solutions. So some of these included the establishment of a district-level task force to improve interdepartmental coordination. The elected representatives worked with the district TB office and the district health administration to encourage private sector healthcare providers to be more proactively supportive of the NTP and to notify cases and to follow protocols. And also, they were able to encourage work with the NTP framework to see how to improve human resource capacity at the district level wherever it was needed. And so what this also then showed us was that there was a role for them to play in mitigating the impact of COVID-19 on TB care as well. 5 of these elected representatives, or champions as we like to call them, were able to review the status of the TB program in their districts and look at TB care and delivery of services. And based on where they saw gaps, some of the suggested actions were that they looked at expediting pending payments for the Nikshay Poshan Yojana, or what is the nutritional support scheme in India, where they were delayed for whatever reason. And also working with the private sector to ensure that providers were notifying all the TB cases that they were treating to the TB program, despite all the challenges in infrastructure and logistics that the pandemic had brought with it. And so I come to my final section. Sorry, I just skipped that, which shows us, what kind of limitations we saw and lessons that we learned. It's very important to improve the efficiency of the overall process. Right now, we were using hard copies that required manual entry of data. Someone had to go back and forth. We had to coordinate with this. This could always be improved if this were digitized, and it would become far more easier if data was just ported into a platform which these elected representatives could view and then act on. And of course, this can actually be used beyond just elected representatives for other health administration. And we did do something for this, like this for one state government, but of course it has utility beyond that. So from here, the three things that we really would need to do is institutionalize the tool, bridge the gap between elected representatives and implementers. So we could look at how this can be scaled up, because it does have use. And of course, look at where, specifically in the COVID-19 context, it can play a role in ensuring continuity of care and stopping interruption of services. So thank you so much for listening, and thank you for taking the time today.
Hello, everyone. I'm Alex Chamwes from Uganda TB Implementation Research Consortium, Makerere University. I'm going to briefly present research we've been carrying out to determine adherence rates and acceptability of 99-dose tuberculosis treatment supervision in Uganda. I have no conflict of interest to declare. 99-dots is a digital adherence technology that has been widely used in India to improve adherence to TB medication. We used human-centered design to adapt the 99-dots platform to the Ugandan context. The adapted 99-dots platform comprised of envelopes with up to 4 patient choice of image on the front cover, space to write the health worker's name and contact, simplified pictorial instructions for taking pills, motivational and educational messages on the inside cover. The providers, the patients receive SMS reminders every day if a dose has not been taken. The patients then call the toll-free numbers revealed when daily medication is taken. And when they call the system, they hear educational or motivational messages. The calls get logged as taken doses on the 99-dot server. The providers then access the patient's dosing history via smartphone app and follow up on the non-adherent patients through phone calls or home visits. This was a step-to-edge pragmatic trial carried out at 18 health facilities in Uganda between January 2019 and July 2019. In month 1, all sites were using the standard of care, which was the DOT, and beginning January 2019, every month 3 sites were switched to intervention. By July, all sites were using 99-dots intervention. The study population comprised of adults with pulmonary TB, initiating treatment at these 18 facilities. For the implementation sub-study, we also conducted surveys with a random sample of 5 women and 5 men using 99-dots from each facility, and also did provider surveys with 1 to 2 staff at each facility using 99-dots. We extracted patient demographic data and adherence data from the 99-dots server. In addition, patient and provider surveys were conducted to assess feasibility and acceptability of the adapted 99-dots platform. The survey design was informed by the theoretical domains framework, the COMB behavior change model, and the unified theory of acceptance and use of technology. From the primary trial, 50.3% of the intervention patients were enrolled on 99-dots within the first month of treatment. Majority of the patients not enrolled lacked access to a phone. Among the patients enrolled on 99-dots, the treatment outcomes were significantly improved. The patients using 99-dots were 2.89 times more likely to successfully complete treatment compared to patients in the control period who were not using 99 dots. We found similar improvement in secondary treatment outcomes. For instance, for the patients completing the intensive phase and then those lost to follow-up. The patients enrolled on 99 dots were 4.3 times more likely to complete the intensive phase than those not using 99 dots. And the intervention was also protective of loss to follow-up. For the adherence, adherence here is recorded by both direct calls by patients and the manual doses which are added by providers after ascertaining that the patient took medication, but for some reason or another was unable to call 99 dots. A total of 1,528 patients were enrolled on 99 dots during the study period. Of the expected 229,487 doses, 54% were confirmed by direct patient calls. After incorporating the manual doses, the total doses reported as taken were 92%. 95% of the patients reported adherence greater than 50%. 1,160 patients, or 76%, had adherence greater than 90%, and 672 patients, representing 44%, had adherence of 100%. From our implementation surveys, 99 dots was well received by patients and providers. 94% of the patients said that the reminders helped them to remember to take their TB medication. 99% of the patients said 99 dots helped them feel more connected to their health workers. All patients surveyed said they would recommend using 99 dots to others. However, 51% of the patients reported occasional difficulty in making calls due to low battery or poor network. From the provider surveys, 21 out of the 22 patients surveyed reported reduced workload. 18 out of the 22 patients, providers reported occasional difficulty in accessing 99 dots dashboard due to software malfunctions. In conclusion, from our study, we saw that patients using 99 dots achieved high levels of adherence. The patients and providers found the technology acceptable and convenient, despite challenges of poor network and software malfunctions. We also found that the reach was at around 50%, where a majority were not enrolled due to lack of access to a phone. And we would recommend that for such an intervention to reach the most vulnerable or the poor, probably there is need to provide low-cost phones to such patients. We thank our colleagues at the UCSF Center for TB, headed by Adithya Katamanchi, Makerere University College of Health Sciences, Dr. Achilles Katamba, Uganda NTOP, Dr. Stavia Turiahabwe, and the health center staff and patients for participating in this study.
Good morning, afternoon, and evening, everyone. My name is Alvin, and I am from the Saw Swee Hock School of Public Health, National University of Singapore. Thank you to the Union for this opportunity to present our work at this conference. Before I begin, I would like to declare that I have no conflict of interest to report. Today, I will be discussing a mixed method systematic review and meta-analysis that we have conducted to investigate the determinants of delayed diagnosis and treatment of TB in high-burden countries. TB control and elimination is a critical challenge in many countries. However, the burden is disproportionately borne by 30 countries, mostly in Asia and Africa, accounting for 87% of the world's TB and TB-HIV cases. In 2018, nearly 1/3 of the people with TB were estimated to be undiagnosed globally. The delay in diagnosis and treatment is not only detrimental to the patient's prognosis, but also perpetuates TB transmission in the community. Therefore, identifying the risk factors that lead to delayed TB diagnosis and treatment is imperative in developing interventions to achieve a substantial reduction in TB incidence. We conducted a systematic review and meta-analysis to derive the determinants and duration of diagnosis and treatment delay of pulmonary TB in high TB burden countries. In this study, our primary outcomes were patient delay, defined as the time interval between the onset of symptoms and the first encounter with healthcare professionals. Health system delay, defined as the time interval between the first encounter with healthcare professionals and the diagnosis of pulmonary TB. Treatment delay, defined as the time interval between TB diagnosis and TB treatment initiation, and total delay, defined as the time interval between the onset of symptoms and TB treatment initiation. As there were no universal cutoffs to a duration that constituted delay, we treated delay in this review as to how they were defined in individual studies. We included study population that comprised people with TB, presumptive TB, stakeholders in TB management and control, and other key populations for TB. We included both observational and qualitative studies published in either English or Chinese language. The quality of the selected non-randomized quantitative and qualitative studies was critically evaluated using the Newcastle-Ottawa scale and the Critical Appraisal Skills Program tool, respectively. For data synthesis, we described the independent variables that were significantly associated with the different types of delays. We pulled effect sizes of covariates if data were available in more than 2 studies and duration of delays by meta-analysis using a random effect model. We quantified between study heterogeneity using chi-square statistic and I-square. We extracted qualitative findings and sample quotes reported in qualitative and mixed method studies in verbatim and applied thematic analysis to categorize the textual references. A total of 4,878 records were identified, and after removing duplicates, non-relevant titles and abstracts, and studies that did not fulfill the inclusion criteria, 124 articles were included in the final review. These studies described data from more than 149,000 presumptive TB cases and people with TB, 1,600 in-depth and structured interviews, and 80 focus groups from 19 countries in 3 continents. A total of 14 countries were classified as lower income and lower middle income, and 5 were classified as upper middle income. Of the 30 high TB burden countries, 11 countries were not included in this review, either due to data unavailability or the lack of key outcome data. The overall median patient delay was 28 days, health system delay was 12 days, and treatment delay was 6 days. All forms of delays were generally longer in lower income and lower middle income countries compared to upper middle income countries. In the meta-analysis, we found that females and rural dwellers were more likely to delay care seeking for TB, with a pooled odds ratio of 1.14 and 1.56 respectively. As most of the independent variables were grouped differently using varied cutoffs, we were not able to standardize them all. Therefore, meta-analysis were only performed for selected variables. While many of the relationships that we explored were not statistically significant in the meta-analysis, we also summarized all the findings narratively and performed thematic analysis for qualitative studies. From the socio-ecological model perspective, patient delay was mostly associated with individual, interpersonal, and community risk factors such as low education, unemployment, poor TB knowledge, long chains of care seeking prior to TB diagnosis, stigma, and financial insecurities. Health system and treatment delay were mostly associated with organizational or institutional and policy risk factors such as the lack of resources and materials, complex referral and administrative procedures, poor practices, and ignorance of TB among healthcare workers, and accessibility to healthcare. In this study, we strive to be comprehensive by systematically assessing and reviewing quantitative and qualitative studies using validated tools and processes. We also found high levels of heterogeneity amongst the studies, which is well within the expectations of the review team, as we retained the definitions of delays as to how they were defined in individual studies for comprehensiveness. We incorporated heterogeneity into random effects model with inclusion of confidence interval for the pooled odds ratio for pragmatic interpretations in a real-world setting. This review did not include data from all 30 high TB burden countries due to the absence of key outcome data and research activities. In conclusion, this review highlighted the gaps in knowledge and provided insights into the determinants of delayed TB diagnosis and treatment in high burden countries. To improve access to TB services and early diagnosis, specific vulnerabilities such as sex disparities in care seeking, being older, and geographic isolation should be recognized and addressed through tailored approaches. It is also crucial to improve consciousness of the society regarding TB to battle stigma. Networks of support from within the families, the grassroots, and institutions could create an empowering environment for early care seeking, treatment adherence, and treatment success. In contrast to patient delay, the shorter health system and treatment delay were encouraging. Nevertheless, TB programs should strive to test and treat TB through the adoption of WHO recommendations for same-day TB diagnosis to further reduce TB transmission and mortality. Higher-level policies and interventions such as health system strengthening, universal health coverage, and the provision of sustainable social welfare schemes are important to reduce delay, improve access to TB care, and ultimately achieve the global TB targets. We would like to thank Dr. Asano Miho, Ms. Annalisa Chin, and Ms. Ratnala Naidu for making this study possible. With that, thank you for your attention.
Hello, everyone. Thanks for your interest in my study. First, I wanted to declare that there is no conflict of interest to report the data of this abstract. And let me introduce my topic, which is the effect of depression and anxiety and other risk factors on adherence in the Philippines. Regarding the background, I first wanted to show the association between TB and depression. There are a range of risk factors which is associated with TB and may lead to depression, like psychological and financial factors due to losing the work. Also weight loss and fatigue, which make person disabled to do the normal activity and daily activity, hypoxic condition, which irritate the TB patient, and also a medication side effect. Other comorbidities like diabetes and cardiovascular disease, and overproduction of pro-inflammatory cytokinase. On the other hand, some risk factors may have a causal effect of depression which lead to TB, such as increasing the pro-inflammatory secretion like cortisol, which is reduce the immunity and person become more susceptible to get TB. Also, depression may lead to HIV through the intravenous drug user and unsecure sexual behavior, which reduce the immunity and also person becomes susceptible to TB. And being homeless and poor living condition, alcohol and smoking substance abuse may lead to TB and poor nutrition. Regarding the objective of this study, the primary objective is to assess the adherence to TB treatment throughout the planned treatment duration among Filipino TB patients, and we would like to see if it's associated with depression, anxiety, stigma, and social family support and malnutrition. Regarding the methodology of this abstract, the study design is nested cohort within a main STAT TB treatment cohort study. We recruiting the adults starting DS and MDR TB treatment, which following the WHO shorter regimen in 3 regions: Western Visayas, which include 5 sites, Center Visayas, which include 5 sites, and National Capital Region, which include 1 site. Regarding the data collection, We are asking the structure questionnaire using the open data kit to measure depression through the hospital and anxiety depression scale, adherence through Moresky scale and number of doses taken in the last 7 days, multi-dimensional scale of perceived social support to measure the social and family support, and TB stigma scale to measure stigma. Regarding the all over time point for this study, once the person diagnosed with TB, we recruit that person within 5 to 7 days of starting the treatment, then assign a follow-up meeting appointment at end of intensive phase, which is 2 months for DS and 5 months for MDR, middle of continuation phase, which is 4 to 5 months for DS and 6 to 7 months for MDR, and the last follow-up at end of continuation phase, which is 6 to 8 months for DS and 9 to 12 months for MDR. Regarding this abstract, I will show the result at baseline, which measuring the depression, anxiety, stigma, social family support, and body mass index. Also, I will show the adherence after 1 month follow-up. As we can see, this table is showing showing the risk factors and the adherence by region. As we can see, non-adherence were 29.2%, depression was 7.2%, anxiety 32.2%, low family support, social and family support 16.9%, stigma 43.2%, and malnourished 21.6%. As we can see, the proportion is different by region. So at national capital region, we had more non-adherent patient with 69.2%, more depressed patient with 23.1%, and more malnourished patient with 23.1%. While in the central Visayas, we have more stigmatized patient with 64.5%, and for the region Western Visayas, we have more anxious patient with 34% and low family support with 20.4%. This table is showing the association between the risk factors and the non-adherent. As we can see, the region and depression are associated with non-adherent with 0.005, and anxiety is also associated with non-adherence with 0.017. As we can see here in multi-variable analysis, that patient or the person who are depressed are 2.56 times more likely to be non-adherent, and person who are anxious are 2 times more likely to be non-adherent. So in conclusion, depression and anxiety are common among Filipino TB patients and independently associated with non-adherence behavior. The social and psychological intervention may improve the medication compliance level among Filipino TB patients. At the end, I wanted to acknowledge Professor Sharon Cox, the main supervisor and founder of this study, the Ministry of Education, Culture, Sports, Science, and Technology in Japan, National TB Control Program in the Philippines, and our local collaborator nutritional center in the Philippines. And thank you.
Yeah, I'm Rodrigo Ninogurio. I work with the University Research Company on an integrated TB-HIV project in East Central Uganda. I'm going to be presenting the impact of the HIV test and treat policy on the incidence of tuberculosis in HIV populations in East Central Uganda. As a background, early antiretroviral therapy is known to reduce the risk of tuberculosis among people living with HIV. In Uganda, eligibility for antiretroviral therapy initiation changed from CD4 cells less than 350 in the year 2009 to CD4 cells 500 by 2015, and in 2016, Uganda adopted the test and treat antiretroviral therapy initiation policy, irrespective of the CD4 cell count. So this policy's impact on TB incidence among people living with HIV in Uganda has not been studied. So the USAID's Regional Health Integration to Enhance Services in East Central Uganda project conducted this study to determine TB incidence before and after this policy's adoption. This was a retrospective study where we collected and analyzed data for individuals 15 years or greater receiving antiretroviral therapy at Jinja Regional Referral Hospital between January 2005 and December 2018. Data including TB status and year of initiating antiretroviral therapy were collected. Client data were categorized into 3 eras based on the date of antiretroviral therapy initiation. That is era 1 for clients that initiated antiretroviral therapy before the year 2009, era 2 for the clients that initiated antiretroviral therapy between the year 2009 and 2015, and then era 3 for clients that initiated antiretroviral therapy 2016 and after, that is during the test and treat policy. Cumulative TB incidence was calculated as the proportion of total new TB cases out of the total patients starting antiretroviral therapy in each of the 3 eras. Odds ratios were determined for association between treatment era and TB incidence. The results were that out of the 3,941 clients, 383 representing 9.7% developed TB while receiving antiretroviral therapy. The cumulative incidence of TB in each of the 3 eras was 16.1% in era 1, 9.5% during era 2, and 6.3% in era 3. The odds of TB during era 1 and era 2 were 2.5 times and 1.6 times respectively greater than the odds of TB in era 3, both eras with a significant p-value and confidence intervals. We concluded therefore that incidence of TB progressively reduced with each era and was lowest during the era of test and treat policy. These results suggest that the policy had a positive impact on reducing the incidence of tuberculosis among people living with HIV in Uganda. We thus recommend the widespread adoption of this policy to improve timely initiation of antiretroviral therapy among people living with HIV. Thank you.
Working with the National Institute for Medical Research in Mbeya, Tanzania, I'll be presenting our work on the utility and benefit of tuberculosis molecular bacterial load assay, TB-MBA, to monitor TB therapy in a resource limited high burden setting. Next. Okay, so treatment of tuberculosis required 6 months, and because of the longer duration of treatment, adherence is a challenge for many patients, and around 5% of the people develop relapse TB after successful treatment. And again, drug-resistant tuberculosis are becoming a global problem. Around 18% of individuals develop resistant TB after successful treatment. And also we have about 4% for people who have new TB disease. So for that reason, effective methods are needed to monitor TB therapy. Just because standard culture and microscope methods which are used at the moment have many limitations, as we know that M. tuberculosis grows quite slowly, so real-time monitoring is impossible through growing M. tuberculosis in culture methods. Next. So the tuberculosis molecular bacterial load assay is a PCR-based test which detects schizonous ribosomal RNA of M. tuberculosis using reverse transcriptase PCR. And we normally target schizonous ribosomal RNA because it's more abundant and more stable compared to other RNA species like messenger RNA. It falls in response to treatment quite well and provide results in hours compared to weeks on standard culture. And the most important thing is that it's not affected by sample contaminations. Next. So the TBM berry has only 3 steps. First, you have to extract RNA from a patient sample, and then you do 1-step PCR, meaning that amplification and transcription of RNA into complementary DNA occur in the same tubes. And then you do data analysis using the standard curve, which is pre-developed from RNA templates with known concentration from M. tuberculosis cells. Next. So our objective of our study was to evaluate the utility of MBRA for treatment response monitoring in clinical settings. So we had 2 specific objectives. One was to explore the relationship of bacterial load decline with resolution of clinical signs. And the second was to explore the performance and benefit of MBRA compared to routine microscope and culture. Next. So the study was conducted in Mbeya, Tanzania, located in southwest in Tanzania. The project involved 18 to 65 years old patient diagnosed with pulmonary tuberculosis by gene expert and smear microscope. We included only drug sensitive TB patients. So we assessed the decline of clinical sign from baseline throughout month 6 of treatment, and we performed sputum-based tests at baseline week 2, months 2, 5, and 6 using culture, TB and smear microscope. Next. So clearance of M. tuberculosis load corresponded with the resolution of clinical sign, and more particularly with TB and cough, compared to other clinical signs such as night sweat, chest pain, and sputum production. In total, around 13% of the patient had cough by end of month 6 of treatment. And this concurred with previous studies which show that persistent cough during treatment have been associated with culture positive and relapse TB after successful treatment. And in our study, around 3 patients out of 6 of the patients who had cough, they had TB positive by TB and culture at month 6 of treatment. So this finding suggests that in absence of bacteriological markers such as TB and culture or microscope, cough may be used as a clinical marker to assess treatment response. Next. Again, the MBRA detected low MTB bacterial load in follow-up samples that had culture and the microscope negative results. So if we can look at month 2, around 6% of the patients were TB MBRA positive, but only 80% were smear microscope positive, LOJ only 18%, and MGT culture only 28%. So you'll see by using MGT culture as a gold standard, it detected only half of the patient at month 2 whom were TB MBRA positive. Next. Again, the real benefit of tuberculosis molecular bacterial load assay was that it was able to generate valid negative or positive results in treatment follow-up with VST at the time when MGT culture was negative, was an invalid result or indeterminate due to contamination. For instance, you can look at month 2 and month 5 again, as well as month 6 in treatment. Around 48% of the individuals were having MBRA positive, valid results for the samples which had MGT result indeterminate. The same at month 5, where you have 42% of the patient had missing culture result due to contamination, and at month 6, about 50% of the patient has no MGT results. So this means that using MGT culture results, you might lose majority of data in follow-up during treatment compared to MBRA. So this means that by using TB MBRA, we might be successful to assess treatment response for the majority of patients because majority of the data will be valid and because the test is not compromised by contamination present in the sample. Next. In conclusion, dissolution of CAF corresponded with bacteriological clearance measured by TB MBRA culture and microscope, and MBRA provide valid results in follow-up sample for MGT culture with indeterminate results due to contaminations or false positive, and MBRA offer real-time results for monitoring of tuberculosis treatment response. Further studies are required to establish the relationship of MBRA with clearance of clinical sign and its impact on patient outcome in real settings. Next. I would like to appreciate the support from University of St. Andrews, led by Professor Gillespie and Dr. Ntinginya, the director of Mbeya Medical Research Center in Tanzania, together with Dr. Issa Saad from the same institution. And also I would like to appreciate this funding support from the Commonwealth Scholarship in the United Kingdom, University of St. Andrews, and Panacea Consortium for supporting this study financially. Thank you very much.
Hello, everyone. I greet you all and welcome you to this session. My name is Dr. Herbert G. Samba. I work for the USAID Defeat TB project. The USAID Defeat TB project supports Ministry of Health Uganda to improve TB case notification and treatment outcomes in Uganda. And part of what I'm about to share is part of the work that Defeat TB has done in central Uganda. Yeah, I have no conflict of interest to declare for this presentation. And I'm presenting this on behalf of a team that has put this work together. Yeah. Next slide. Yeah. TB, you realize at the end of this presentation that TB care process analysis is effective in treatment retention and treatment success rate reduction, improvement. Next. Yeah, as part of background, TB is a major contributor to the global burden of disease. And according to the 2019 Global TB report, the treatment success for people newly diagnosed with TB was 85% versus the 90% target for treatment success rate. In Uganda, between 2002 and 2016, the treatment success rate stagnated between 70 and 75%. This was way below the national target of 85% and the global target of 90%. Yeah, it's notably known that TB treatment retention is a major driver to treatment success rate, and therefore efforts of working on improving treatment success rate need to focus on retention retention of patients on treatment. Yeah, Defeat TB in April 2019 conducted an assessment of treatment retention to care, and it was noted that only 17% of the facilities in its focus districts were meeting the 85% national target. Therefore, it focused on working on improving treatment retention so as to contribute to treatment success rate improvement. Next. Yeah, following that intervention, 30 health facilities were organized into an improvement collaborative. And these were supported. The teams there were supported and oriented onto process analysis and quality improvement tools. Yeah, the teams were supported by Defeat TB and guided on assessing performance and conducting root cause analysis for their respective care processes. And in so doing, they were able to identify root causes. Thereafter, created process changes to address the root cause analysis and the major root causes to treatment, to TB care. Yeah, throughout this implementation, changes were implemented by the teams, tested, and improvement was seen. Next. Yeah, as part of the results, we realized that the number of facilities, the proportion of facilities that were meeting the standard gradually improved from the low 17% prior to the intervention to as high as 80% by December 2019. Similarly, the treatment success rate also improved, and we noted that by the end, by the Jan-March quarter of 2020, the treatment success rate in the districts had hit the national target of 85%. Next. Yeah, additional results from this also were, there was the TB performance teams were established at some of the facilities, and these were teams that looked keenly on TB performance on a regular basis. They were established where they were not, and where they had been, they became more functional. Yeah, TB clinic days were also established. Before the intervention, a number of facilities did not have TB clinic days, but as a result of intervention, TB clinic days were initiated and created. Yeah, patient flow at the facilities during the clinic days was also redesigned to ensure that the process of care gaps are eliminated to offer better care. Next. Yeah, as part of conclusion, TB care process analysis and implementation of the corrective changes at TB treatment facilities improves TB patient retention on treatment and treatment success rate. The results of this intervention provide lessons that could guide the scale up in places where treatment success rate is necessary. Yeah, thank you so much for, I can't end without acknowledging key players to this piece of work. That is the health workers and the district authorities where this work was implemented, the Defeat TB project and the URC staff in general who contributed to this work, the National TB Leprosy Control Program and Ministry of Health, Uganda, and also the United States Agency for International Development. Thank you so much for listening to me.
Well, hello, everyone. That was really interesting. We had some excellent presentations, and thank you for watching. And I'm really pleased that we have all panel members with us right now to go into some questions and answers. So to take up two of the questions that were posted in the Q&A, and I think I would like to ask Hend. Thank you for your stories in the Philippines. And the two questions that came up during your presentation. One was, could you elaborate a little bit more on the rural and the urban differences, and if you see any big differences between those? And the second question is about self-reporting. Given that you're having looked at people with depression and mental issues, do you feel that that influences their self-reporting, and whether that has any differently reporting on non-adherence or adherence? So if you could maybe answer those questions. And then I would like to ask any of the other panel members, after Hend has spoken, would you like to comment on these points, any of these points in general as well? So then you can come in if you would want to. But let us start with Hend. The floor is yours.
Thank you for that question. Regarding the first, the effect between urban and rural, yes, there is difference, but so far at that point, I cannot judge, because as we can see that in Manila, consider urban area, the number of participants is slightly limited compared to others. So we cannot generalize that, but according to previous literature review, there is an effect measure, like people more in urban area are more depressed and more suffering from more risk factor like stigma and other things compared to rural area. For the second question regarding the effect of mental health on reporting adherence, yes, it could affect mental health for reporting the adherence, as people are trying not to be judged or not to be blamed not to take their medication, plus also the side effect they are suffering from the treatment and also from their social life and from their feeling could make a big barrier for that. Hopefully I could cover that question so far.
Yes, that was great. I think you covered some of those questions, and we will keep looking at the Q&A to see if people have more questions. In the meantime, I would like to ask Alex, from your research and work that you've done and looking at with the 99 dots, you've also looked at adherence. Have you come across any issues about what Hend has been talking about, mental health or depression? And could you comment on that maybe?
Thank you. I will start maybe by answering the question that was raised by Helen. Unfortunately, we did not conduct validation of 99 dots in this study. The trial was highly pragmatic. However, there is still a window for us to do the validation if the resources really allow. We still have patients using 99 dots. It would be really interesting for us to conduct one.
Yes, I think so. Hend, I think there's been an additional question to if you could elaborate a little bit more on how you measure the non-adherence and how you define non-adherence.
Well,
oh, sorry, Alex, this was to Hend.
Okay, thank you. Regarding adherence, we measured using a Moresky questionnaire, which is 8 questions and measuring the adherence for the last 7 days. This scale is validated and measuring adherence as a cut of 0.6. So the score, it's kind of scores for each question. If a patient record less than 6, we consider them non-adherence, but if it's 6 and more, it's considered as adherent. So it depends on the score of the validated questionnaire, Moresky scale.
I think that would answer Christian's question. And Christian, if not, then please come back in the Q&A and I will put it forward again. I would like to ask Alvin, from the work that you've done and looking at the different determinants, I'm sure you can comment on all of these aspects. And would you like to further elaborate a little bit more on, for example, the issue of depression and mental health and how that is an impact factor? But more in general, I would like to ask you, like, what do you really see as one of the key factors, the key determinants that the TB programs need to take into account?
Thank you, Petra, for the question. Well, I think in our study, we sort of highlighted that the delays are multifactorial. It is really quite difficult to pinpoint one particular factor that is extremely prominent that would lead to delays. We looked at it from different levels, from individual to interpersonal to community, all the way up to the policy level. And we see that in certain countries, even though they are in the lower income and lower middle income countries, they sort of fared pretty well in some of the levels, like say in some of our work outside of the systematic review in some lower middle income countries. They might have some issues with logistics, diagnostics, access to diagnostic services, but we've seen very strong community support and the network that they could have, and that support could have helped to encourage people to seek care. Whereas in some upper middle income countries, we've seen examples of people getting a bit complacent about TB, and they don't think TB is a problem anymore. And when they're sick, TB is not the first thing that come to their mind. So it is multifactorial. I can't pinpoint one, but I think national program in general should sort of take a blanket approach, evidence-based approaches, be creative, find out the gaps that is context specific to your country, to your context, and try to address from there. That's what I think. Thank you.
Thank you. Yeah, I think that's really well answered, and absolutely, it's definitely is multi-layered, and all the different factors are connected. And I would actually like to bring in an Indira here. It's not directly related, but I think, Indira, your work with the parliamentarians is actually at a different level really an important issue when you look at the support to TB programs and all the health facilities. So would you like to just comment a little bit on the overall title of our session is it a mission impossible or possible? Would you like to take on that challenge and let us know what is the one main thing, if you could give one main thing that would make it a possible mission?
Thanks, Petra. I have to admit, there is no, unfortunately, there's no one right answer, and there's no magic bullet, there's no silver bullet for it. But I would say that, it's extremely important to ensure if we're able, it's not mission impossible. It definitely is possible, but it does need whole of society involvement, which is really why we looked at this particular piece of the entire puzzle. We live in an ecosystem that and public health is really determined, and the success of programs is determined by not just the provision of services from the supply side or the uptake from the demand side, but also all the extraneous influences around in the environment and the policy environment and the leadership that contribute to it. So it's extremely important that we have, and I know this is something that we talk about regularly at all kinds of platforms, but we have to have leadership at every level of governance, at the national levels, at however countries are structured, at their states, and down to their district or provinces and their communities. Leaders need to be involved to bring everyone on board. You have to have the right kind of, therefore, interest and that sense of urgency, so that it trickles down into supportive policies and financial prioritization as well. And of course, we already know that the programs need to be in place. Service delivery needs to continue, and we've seen this during the pandemic that it needs to continue uninterrupted. But for all of those things, I think you need involvement of decision makers at every level, including more so at the community level as well.
Yeah, absolutely. That's really great, and thank you so much for highlighting all those points. I think that you hit the hammer on the nail. So that's really great to have the input of the policy level. But if we go back to more of the demand side, as you have outlined it, the level of where the people that are actually suffering from TB, I would like to ask Herbert. So how you have looked at the interventions and basically the retention of TB patients, and obviously that's connected to political will and overall support from all systems that we're talking about. But can you outline for us, is it a mission possible or impossible? And what is the key opportunity to make it a possible mission?
Well, thank you so much for the question. I would actually say when it comes to patient retention into care, that it is the collective effort in the sense that the patients themselves have a significant role to play. So is the entire system around them, be it the people they live with, the healthcare providers, the policymakers, yeah, mentioning as examples. So indeed, it is a possible mission, but with the cooperation and participation of really everybody who has a role in it. Thank you.
Thank you, Herbert. That was really an insightful comment. I think I'm going to give the floor to Razia and as co-moderator, and let her take some of the questions forward. Razia?
Thank you so much, Petra. And I think it's really an interesting discussion going on. And it is a possible mission with all the mutual efforts of everyone throughout the world. And I think in this session, we heard a very powerful discussions, especially I would like to start with the first one with the interaction with the member parliament. So my question would be to Indira first, and then I see another question on 99 doors, if not taken already. So Indira, I want to ask you, because in Pakistan, as well as you know, that we are also with chasing high burden for tuberculosis, and we have high targets set on, and also we have, parliamentarian caucus established by the Stop TB Partnership here. So I think your presentation is quite interesting for all of us in the country and in the region, of course, that because if we want to end TB, we need to have a strong political support. And I appreciate that your pilot intervention with the member parliamentarian has worked very well. So would you like to tell us more about like how you linked with the dashboard, and was it already ready, or you set some indicators for the dashboard, and how receptive it was from the member parliamentarian? Because they are non-technical person. It's most difficult to talk to them. So we want to hear more from you.
Thank you, Razia. Absolutely. This is a lot, actually, but I'll try and keep my answer brief so that everyone else doesn't get bored. But essentially, we, our dashboard was in complete alignment with the metrics that the TB program in India is using to also track its own progress. And what we have done is, of course, focused on some of the key elements, expanded on them a little bit, gone into a little more detail, for example, on notifications, case detection, private sector engagement, because, in India, the private sector plays a major role, as it does in many low middle income and even, middle income countries. It plays a large role in the service delivery as well. We looked at, we included social support. So we've got something called the Nikshay Poshan Yojana, which essentially means, it's supposed to be nutritional support for TB patients. We wanted to make sure that was being, someone was tracking that as well. We're looking at treatment completion, and, overall, I think what was very important, specifically for non-technical folks, is that we didn't delve too much into details on incidents and prevalence, even though kind of indicates that. But we looked at operational aspects, because that is really where a leader can, or a policymaker can help make a difference. They can understand the basics, and showing them the numbers, showing them that data, help them understand the size of the problem, but also helping them look at operational aspects, whether it was related to financial disbursement in their area, asking about if there are any HR, human resources issues, vacancies, and so on. That is something that they can actually take up. These are things that they can actually, come in and do. And intervene in and support in. The idea was that this isn't supposed to be, they're not supposed to take people to task, but really work with the program at a localized level to understand the challenges and find solutions with them and for them. I hope I answered your question.
Yeah, you've answered very well. Thank you. And so Petra, have we taken this question already, that for the $99 to Alex, that if the patient forgot to call, but he takes regular drug, so that kind of patient also included as non-adherence or not? If not, we can move to Alex for discussion.
Yeah, let's go to Alex.
Yes, I'm happy to answer that. Sorry about the background noise. Yes, when a patient does not call in after swallowing, ideally the providers are supposed to follow up on such patients to take they show on the dashboard that if not swallowed, the provider has to follow up through, say, a phone call or even a home visit, and the platform gives a provider a chance to manually mark that dose as taken. And so once the provider does the manual marking, it contributes to the patient's overall adherence. Okay, so it is really a question of engagement with the system on the side of patients, that is through calling to confirm that they've swallowed. But if they do not call in, we expect the providers to follow up and ascertain whether the patients took or not. And if they took, they should manually mark the doses, and that contributes to the overall adherence of the patient.
Right. Thank you, Alex. So my question would be related to you again, that because it's really very interesting to see the adherence from this intervention. So have you also tried to look at cost effectiveness of this strategy? Because obviously it needs a system to establish, and obviously a software and a phone as well for this system.
Yeah, sure. Thank you for the question. We've collected some good cost data, and this is being analyzed. We shall be publishing a paper on cost effectiveness. Yes.
Great. That would help other countries as well who want to scale up. So I see, so among, we have Alex and Bariki. So Alex, we have done with your questions, I think, mostly. So Bariki, my question to you is also, it's very interesting for the MBLA technique that you have shown us. And you have said that it is like you are recommended for this to be scaled up in the, even in the low resource settings. So have you also tried to look at the cost effectiveness for this in order to go for the scale up? You're on mute.
Yes, so thank you very much for your question. So at the moment, we have ongoing studies which are looking for the cost effectiveness studies. So we hope in the near future, we'll come up with a real price of the assay compared to the standard of care test, so that we know the best way we can adopt this test in routine setting. Thank you.
Great. Yeah, thank you. So now I invite all the panelists for the questions. Petra, so do you have some other questions to the speakers?
I do. I saw en français, il y a une question dans le chat. Mumbolo, merci pour la question. Thank you so much for the question. I will try and translate. The question is basically saying, in many of the countries with low resources, they are very much in a situation of poverty, and this brings situations of access to resources, and not just resources, but also diagnostics. So the question really is, when would we have innovative diagnostics and tools available to us? And I was thinking, Bariki, maybe you want to take that first, since you've been looking at that issue, and you might have some answer to this for Mbolo.
Yeah.
Bariki?
Sorry, I didn't hear well your question. Can you please repeat it?
The question is basically, considering that that most of the low resource countries are actually really poor countries and are struggling with resources, how can new diagnostics or new tools actually be upscaled, and how can we ensure that the access to new diagnostics is made more available? I think it's a big question. It's not a question that's easy to answer, but you might have some thoughts on this, because the work and the thinking that you have shown in your research might give you some little pointers. Or if, Bariki, if you have no questions, maybe someone else wants to address this. I think Alvin, the work on the determinants is maybe also related to this.
Yeah.
Any of the panel members who would like to step up and answer a little bit to Mombolo's question about poverty and resources?
Maybe I'll try. Well, I think it's important
go ahead.
I think it's important to be creative and first of all try to maximize what we have access to, and of course on the other hand try to advocate for more resources. It could be financial or access to more advanced diagnostics that could help with the situation in a particular country, or change the way we work. I think most of my work are based in Cambodia, and one of the things they do to sort of be more efficient in testing is to do a sputum pooling methods, so that they don't waste so many gene expert cartridges when they test people for TB. So that's just one way of trying to maximize resources, improve efficiency. And of course, operationally, we can also think of other ways to improve case finding, for example. And one way that we've been thinking about is how do we incorporate different services into one particular, let's say we have a case finding event, and how do we maximize that case finding event so that we don't do only case finding, but we can also do some sort of contact investigations. We can also think about TPT administration during that time, and not just thinking about, oh, we need to find TB cases and that's it. We can also sort of incorporate other kinds of services like ANC, diabetes, which is linked to TB, and those can be done at the same time as well. So I guess my one sentence answer to that question is, I guess we just have to be creative, look for evidence, and base our approaches on that evidence, and answer and tailor approaches to the gaps that's specific to the country or the context. Thank you.
So thank you so much. I think this is a really an interesting discussion. If anyone else want to add, because we think we have only a few minutes left. So this one is quite an interesting discussion. I just want to have a last question to Hand about her experience with the mental health and tuberculosis. So because here in our country, we have a lot of mental health issues that are, that are documented for the MDR TB patients, but not for the TB sensitive patients. So what do you recommend that it should be for both MDR and sensitive TB patients? And how do you see that it was receptive in your study to do for the TB patients? Because it was all a new idea, if I think so, for the TB patients. But although it is very important, now we are working for the comorbidities as well, along with TB, and among all the comorbidities, depression is on the top. So do you want to say some more about the possibility of adding this to the sensitive TB cases as you have done, and then to scale it up throughout the country?
Thank you for your question. I think, yes, intervention is important for TB patient, especially it's curable and it can be treated. It's important to do kind of consultation, regular consultation with the patient, and also education to make patient understand about the treatment course, and also about how to handle the side effect and the symptoms of the disease, which is one of the major risk factors for having depression. As another study we are doing for qualitative study to digging more behind that, most of the patient, lack of communication with healthcare providers, and also their lack of education about the treatment procedure and the symptoms, that major risk for having depression. So doing such an intervention, I think it will, at least by doing just educational for patient in the health center, will improve their status. And for severe cases, we can report them to any mental health services by government, or reporting to the medical officer, which can help to improve also their outcome and treatment success.
Yeah, thank you so much. So now I think we are coming towards the end, and I would like to thank everybody for interesting and very, powerful discussions. And I think at the end, we all are convinced that it is a possible mission with our collective efforts, and we look forward for ending TB in our lifetime. Thank you so much. Petra, you want to say something at the end?
I think you did a beautiful job closing it off, Razia. Thank you. So I think we all agree that with creativity, lots of action and energy, it will be a possible mission, not an impossible mission. We can do this. We've had some great input and thoughts today. So thanks everyone for listening. We can do this. It's a mission possible, not impossible. Thanks very much.
Thank you.